All right, thank you so much. Well, hello everybody. I know I can't see you out there, but it's nice to meet you if I haven't met you before. So I'm just going to go ahead and get started. I'm going to go through these slides here, and then we'll get to some questions at the end. All right, so today we're talking about understanding cataracts and glaucoma, both pretty common things, things that I see all the time, every day. And to me, I've spent many years learning what these things are and how to treat them, but I just want to make sure everyone else kind of understands the baseline of what we do and what we try to take care of. All right, so just some quick background on me. My journey, I'm originally from Savannah, Georgia. I grew up in Kennesaw, Georgia. I went back to school in Savannah, Georgia for my undergraduate degree at Armstrong State University. And then I went up north just a little bit to Augusta, Georgia, where the master's was played for medical school, where I met my fiance. I did my residency in Charleston, South Carolina at the Medical University of South Carolina. I did my fellowship in glaucoma in Aurora, Colorado, so just outside Denver. And then I now live here in Hanford via my fiance as a F-18 pilot over in Lemoore. So that is why we're here. And then there's just a picture of me operating. So I love what I do. I always say I'm a surgeon. I love to operate. That's fun for me, but the important thing is to know when not to operate. So well, we'll be talking about some other options as well. All right, so what I focus on, so cataracts and glaucoma. So I did do a fellowship in glaucoma, but just as of everybody else is trained in ophthalmology residency, we also learn how to do cataract surgery. So I do, that is my bread and butter. That is what I do the most of, but I also do glaucoma surgeries as well. So in the intensive incisional glaucoma surgeries, in addition to cataract surgery. So big picture, what is a cataract? Is when the lens in the eye that sits behind the colored part of the eye, the iris, it gets cloudy. As you get older, as you have more birthdays, it's just part of the natural aging process of the eye. I explain it like looking through a cloudy window. So it's going to blur the image coming into the eye. So that way it doesn't matter when you have the best glasses possible in front of your eye. If the window is cloudy, if the lens is cloudy inside your eye, the picture on the other side is going to be cloudy as well. Glaucoma is damage to the optic nerve, which is the cable that connects your eyeballs to your brain. So if you think about it, if you have damage to like a TV cable, then the picture's not going to come out clear either. So it's all kind of just think about it like a camera or like a TV, anything that has cables in a lens system. So if there's a problem with any of those things, you're going to have trouble with the picture. Different problems with different goals, though. So when I ask people, do you have a family history of glaucoma? And someone says, oh, my parents had cataracts. Those are actually two very different things because as you can kind of see in this little diagram here, they're in different parts of the eye. So, but I treat both of them and I can treat both of them at the same time, thankfully. So let's talk about cataracts first. What is a cataract? So as I said, it's the natural lens. As when we're born, when we're younger, it's nice and clear. It's kind of more flexible. As we get older, these cells build up and it turns kind of yellowish. Becomes more dense. Some people have more yellow cataracts. Some people have more white cataracts. It's just different from person to person. It doesn't particularly mean anything bad. It's just it is what it is. They're different for everybody. And that's going to cause some blurred vision, kind of yellow vision or glare. Like, especially you're driving at night, you have some oncoming headlights, and you're like, oh my gosh, I cannot see the road in front of me. I'm having trouble seeing the signs. I don't feel safe anymore. That's from that light hitting that kind of opaque yellow lens inside your eye. As we get to older and older age, as that lens becomes more and more cloudy, it can eventually turn like orange. I've seen a black cataract, I've seen a brown cataract. So it's just build up over time. Okay. So I know in the kind of everyone thinks about, oh, is my cataract ripe yet? I don't really like that phrasing. It's not an orange. It doesn't get ripe. It's just about how cloudy it is, because that's what we're looking at when we look in the microscope in your exam is how cloudy is your cataract. So, common cataract symptoms that you should be on the lookout for. So, number one, blurred vision. So, like I was saying before, even if you have an updated pair of glasses, if you feel like, man, I got these new glasses, they're beautiful, they're great, best lenses I could get with all the films and stuff on them, but my vision's still just kind of blurry. I feel like I'm having to like rub my eyes, like it's just not clear. That could be from the cataracts. Again, the glare with headlights. So, having trouble seeing, especially on these country roads out here, oncoming, let's say you're on 198 and there's an oncoming truck in the other lane. They've got their high beams, their bright LED lights, and you're like, oh my gosh, That's from the cataract, can also cause that. Trouble reading small print. So if you feel like you're having to turn on that reading light brighter and brighter and brighter, and you're getting stronger and stronger reading glasses, and you're still really can't quite focus, that would also can be from the cataracts. And colors looking duller. I would say less people kind of notice this. But what happens when that lens becomes more yellow and kind of more opaque over time, it's going to block out blues and greens, especially in your vision. So let's say you get to the point where you're like, wow, I can't really tell the difference. Is this blue or is this black? And oh, the walls in my house look kind of cream color. I think I might need to paint them. Looking at your closet, that's honestly the thing that most people say. It's like, yeah, my clothes just aren't as bright as they used to be, or oh, I'm an artist and I'm just having a really harder time discerning colors. That would be from the cataracts as well. When is it time for cataract surgery? So, the thing I tell patients all the time is just because you have cataracts does not mean you have to have cataract surgery. So, you can be 50 years old and be told you have cataracts, but that's just a finding on our exam. We have to take notes about what our exam findings are. But until your vision affects your daily life, so until you get to the point where you say, yeah, I'm having trouble reading, I don't drive at night anymore because I just don't feel safe doing so, or I just things aren't as clear as they used to be. They're kind of hazy. That's when we start to talk about cataract surgery because I want to make sure that the benefit of surgery outweighs the risks. There's of course risk involved. It is a surgery. They're lower compared to, other surgeries in the body, but it's still risk involved. It's still your vision, and we want to make sure that you will actually notice a benefit in the surgery. Every now and then, however, there are times when there's medical conditions inside the eye where I might say as the ophthalmologist, hey, because of reason X, Y, and Z, I actually recommend that you do have surgery to prevent complications with something else. But that's few and far between. Most people I say, hey, is this affecting your life enough to talk about surgery? But you know what? If you have cataracts and you're seeing fine, you're driving and your vision's legal to drive and you're doing just fine, if it ain't broke, don't fix it. It's not worth a surgery if you're really not going to notice a benefit. So, what happens during cataract surgery, right? People ask, do you take out the eye? Do you put it back? Is it a laser that does all this? Not quite. So, we'll kind of just get into the simple steps of it here. So, step one, I think of the cataract like the lens is shaped like an M&M. And it's kind of covered in this wrapping paper type stuff that supports the lens. It's called the capsule. So I make a very, very small opening into that wrapping paper, that capsule that holds that lens. Step two, I use ultrasound, and it's the device that we use is about the size of a pen to break up and kind of suck out those cataract pieces. So once all that's out, the cataract's all cleaned up, and you've got that kind of capsule support structure all clean and empty. I put a new clear lens implant. I can't even, don't have a way to show you how big it is, but it's very, very small. It gets rolled up like a taco and it goes into your eye and it opens up inside that same capsule. So it just takes the place of your old cataract. It was a cloudy cataract. It's much, much smaller though, and it's clear, of course. And then that lens implant, the cool thing about it is that it's made out of acrylic. It lasts forever. The body doesn't reject it. It doesn't need to be replaced. So some things can happen later where your vision might get cloudy, and we'll talk about that later down the line. But the lens itself does not need to be replaced. It's good forever and eternity. So, am I supposed to have perfect vision after? I have patients that say, "Wow, my friend said that they woke up the next day and they had almost X-ray vision. Everything was so perfect." That is not the norm. That's fantastic if that happens. It does happen where people the next day have 20/20 vision, but that's not expected for everybody. And it's very, very normal to have blurry vision the next day, the next week, and even after surgery. Not everyone has a perfectly healthy eye that's going to set you up for that perfect vision. Some people will still, most people actually, will still need to have glasses for their best vision. So, there's still aspects of your vision that can be corrected with your glasses, including reading vision, computer vision. Maybe you have some astigmatism in your vision. It's not abnormal to still need glasses after cataract surgery. So don't expect that this is a perfect every single time everyone's going to have 20/20 vision. It's not always the case, and we will explain it to you if you're having trouble. Oh, my vision's still not clear. We will take our time to try to figure out why and explain why. Is it dryness? Do you need glasses? Is there something going on in the back of the eye? what's happening, but there's typically always an explanation. And again, the goal of just a standard cataract surgery is to give you useful vision. To me, useful is 20/20, and I'd love that for everybody, but it's just not always possible. But we do our best. We have great calculations, great machines. The surgery is really good, but we just can't expect perfection for everybody, and that's okay. I want you to be able to be happy with your vision. That is my goal. Sometimes what we call instead of 20/20 is 20 happy. Are you functioning well? Are you doing well? Are you doing all the things you want and need to do without issue? Great. I'm not so worried about the number on the eye chart. Um, and that's what the standard lens that's covered by most insurances. Now, there are other lens options that we will would talk about in a cataract evaluation. I call the premium lenses, or sometimes I call them the fancy lenses. Those are the lenses that try to get you out of glasses for more things. And those are not covered by insurance because they consider them cosmetic, because we can get you seeing just fine with glasses. So that's why they don't cover them. Those are a few $1,000s each eye. So we are very, very picky about who gets those lenses, but I'll kind of get into that in a little bit. So, the first question I ask patients during a cataract evaluation is tell me about your daily activities, hobbies, and work. What do you do? Do you drive a lot? Do you read a lot? Do you just like to watch movies or something at home? Are you cooking all the time? And try to figure out what is the best thing to do for your vision with what you do every day. Are you someone that's super active that really doesn't want to be in glasses? And are you hiking, going to hike Mount Everest and glasses would get in the way of things like that? Just kind of figuring out for every patient what is going to work best for you after surgery. My next question, would you like to get out of glasses or do you prefer to keep using them? So that's when we start talking about these fancy lens options versus the standard lens option that's covered by cataract, that's covered by insurance. So I would say most patients are totally fine wearing glasses. You're used to wearing reading glasses. You're used to having glasses on for to see things at a computer. If you're totally fine with that, then that's great. But then there's some patients that are like, get me out of glasses. I'm done with this. I'm over it. I want to go hike. I want to ski. I want to swim. I don't want to worry about it anymore. That's important for me to know because that changes the discussion about the lens options that we're going to do. Um, so another thing here is, what lenses are right for you. So I kind of customize, like we just said, visual goals. What do you want to see? What do you do every day? With the lifestyle and hobbies. Are you a reader? Are you a runner? Are you a hiker? What are you doing on a computer all day? And then eye health. That's actually to me the most important thing is your eye healthy enough for these more premium lens options, or would a standard lens option be best for you? Because I don't want to put in a lens promising you the world, and because you have other underlying eye health issues that you're not seeing as well as you had hoped. So it's really, really important for me that I do a full exam face to face, get all of the testing, do a full dilated exam, and figure out, okay, what is actually, regardless of everything that you want for your goals, what is actually going to be the best option for you with regards to your eye health as well. Some people are candidates for everything. Some people are only candidates for the standard lens. So that's a really, really important aspect of it. So either way, though, all of these things kind of circle together and are part of our discussion with lens options and visual outcomes after surgery. Do cataracts come back? So this is what I was kind of touching on a little bit. Cataracts themselves, the cloudy lens does not grow back. But what does happen is a film can grow on the back side of that supportive structure. And it looks almost like you're kind of looking at through like bubble wrap or wax paper. That's the way it looks like when I look through the microscope. And patients have said that too. It's like my cataract came back. Things are just kind of hazy. So what happens is even though we took out the natural lens, there's still little cells being made inside the eye. And by design, they cannot stick and should not stick to the new artificial lens. Well, where do they go? They stick on the back side of that capsule, that support structure. If it becomes enough of a problem that it affects your vision, and you're like, wow, I feel like I never had cataract surgery, like they're growing back. I'm having blurred vision again, and it seems like I need to rub my eyes like it's never clear. I'm having trouble with glare. There's a very, very, very easy in-office procedure called a YAG laser. It is painless, takes a couple minutes. There's no restrictions afterwards. It's very straightforward. It's covered by insurance. That's something we can do afterwards if you need it. All right, so let's move on to talk about glaucoma. So what I did my fellowship in. All right, so what is glaucoma? It is damage to the optic nerve. So the cable that connects the eyeballs to the brain. There's one for each eye. It carries the vision to the brain. So vision comes in through the front of the eye, the signals all get carried through that nerve to the brain. Eye pressure is a risk factor. So that's the thing that I always say when the pressure is too high for your eye, it causes damage to the optic nerve and can cause loss of peripheral vision. However, there's still a lot about glaucoma that we do not know. So, stress, blood pressure, those are lower on the list. Sleep apnea, there's still ongoing studies with all of these things that we don't know exactly how and cannot quantify exactly how they affect damage to the optic nerve. We know that eye pressure is the biggest cause, the biggest risk factor. So, if someone has a really high eye pressure, they have damage to their optic nerve, loss of peripheral vision. Super straightforward, but there are other cases where, well, you can have lower pressure and still have glaucoma. So it's kind of this mix of parts that we're still learning about. We don't know exactly how the damage is caused to the nerve still. Unfortunately, there's ongoing research, but the thing that we know that we can treat, and that's why you always hear us talk about eye pressure, eye pressure, eye pressure, because that is something that we can treat. It is a number that we can measure and that we can treat. But again, there are other things that kind of play into it. Why can't I see my glaucoma? So, because what happens is you can have glaucoma and not have any vision loss, any peripheral vision loss. Because what happens is for a while, you can have damage to your optic nerve and not have any peripheral vision loss at all. And slowly, the more damage you have, it will start to affect your peripheral vision. Well, because it's so far peripheral, you don't really notice it. And your brain kind of fills in missing areas. So you can have a loss of your visual field, but your brain kind of figures things out. And so you don't really notice it. And especially if both eyes are working together, you really won't notice it because your better eye is going to try to, again, kind of hide missing spots, work together, try to compensate. And so glaucoma is a symptomless disease. You don't feel that your pressure is high. And if you get to the point that you've noticed, like let's say you don't see an eye doctor and all of a sudden oh wow, I feel like I'm seeing like a tunnel, I'm only seeing like that much in my vision, then it's probably very severe glaucoma by that point. And that's the trouble about this disease is that you don't know it until you go to an eye doctor and we do an exam and then we can say, hey, we're going to do some testing and then we can diagnose you with glaucoma. That's the tricky thing about it. And it's quite unfortunate that it's completely asymptomatic. And that's why people ask, like, what can I do to prevent it? Just go to your eye doctor. That's the most important thing. We check your pressure, we do an exam, we look at your optic nerve. Sometimes we'll do testing to screen you for glaucoma, other forms of diagnostic testing, because that's really the best way to catch it. You won't feel that you have it. And again, if you've noticed that you've lost peripheral vision, it's probably already severe by that point. So just an example here. So normal vision, of course, we see everything. Early glaucoma, you can see things are kind of graying out in the corners there. More advanced, you can still see a good amount of things, but it's really only clear in the middle. Once we get to, it says extreme, but I'd call it severe glaucoma, is even the central vision gets affected. So it starts out in the peripheral vision loss on the outside and it starts closing in the more damage you have to your optic nerve. And it gets to the point where it can eventually affect your central vision because it just kind of starts to fill in and you lose that central vision as well. So this is the pool analogy, sink analogy. Sometimes we're the eye plumbers, basically, is how I like to think about it. So if you think about the eyeball like a pool, water enters the pool, water leaves the pool. And this pool has a lovely waterfall and a river flowing out of it. But in glaucoma, if we're talking about the pressure being high, what happens is that water leaving the pool, it gets something's happened. That waterfall is blocked, that drain is blocked, and then the pressure goes up. So there's water, so at least in the pool analogy, there's water going into the pool, but it can't flow out. So you have this overflow. And that's when we think about, the drainage structures inside the eye that are responsible for helping maintain the pressure, they're not flowing as well. There's fluid buildup and the pressure is going high. So it's just like this. So, how do we treat that? Treatment number one, we can decrease the water inflow. So, let's say the drain's not working. Okay, well, we'll turn the faucet down a little bit. Method number two, try to open the blockage. So, okay, we're leaving the flow alone. We'll try to open the blockage and help the drainage keep going that way. Number three, neither of those is really a great option. We'll just put another drain in another way. So let's say one pathway is blocked, we'll put in another pathway. And can glaucoma be cured? Unfortunately, no. I hate to say it, but it is a slow, progressive, and is a chronic disease. So some people will say, oh, well, they got rid of my glaucoma because they did a surgery and I don't take a drop anymore. That does not mean that you don't have glaucoma anymore. Once you are locked into that diagnosis and you have glaucoma, and it's for sure glaucoma, that's it. It is a slow moving disease, and it is progressive. My goal, and every glaucoma specialist and any comprehensive ophthalmologist, any optometrist that treats glaucoma, our goal is to slow it down. Our way to do this is by lowering the eye pressure. So we can't stop it, we can't undo it, but the goal is to slow down the progression and to preserve as much vision as possible for as long as possible. And the thing I always tell people is, they're like, what can I do about this? I'm worried about my pressure all the time. Like, what's my pressure? What's my pressure? What's my pressure? So because stress actually is a risk factor for glaucoma. Again, not like a for sure I can tell you a bunch of information about that, but it is a risk factor. But life moves fast, glaucoma moves slow. So, and that's why it takes so long for people to notice that, oh, wow, I've lost my vision. I should go see the eye doctor because it happens so slowly too, and it's asymptomatic. So, your job is to live your life because your life is going to be lived a lot faster and things are going to happen a lot faster than the glaucoma is going to progress. So, my job is to worry about the pressure. My job is to worry about your glaucoma. Your job is to live your life. Again, life fast, glaucoma slow. Live your life. Let me worry about the pressures. And I do. I worry about people's pressures. So, the truth about glaucoma treatment. All treatments, drops, laser surgeries kind of have a shelf life. They don't last forever, unfortunately. We don't have a perfect treatment for glaucoma that lasts forever and halts it to a stop. So they work on a limited time depending on the person. Every patient is different. Eventually, we need to try something else. So this is just an example of kind of a disease progression, treatment progression. So we might start with a laser and then the disease progresses. We might try a drop and then progresses more, try another drop. And then, okay, let's do a surgery now. Great, we're doing fine for a while. Oh, let's try a different drop. Oh, now we got to do another surgery. Again, because it is a progressive disease. This can happen over the course of many years, sometimes over the course of a couple years. It's different from person to person. Um, and some people are fine on a drop for 15 years and they're fine. And again, it's very different from person to person. So let's say you're diagnosed with glaucoma and you're like, well, my friend's been on its drop for 20 years and they're fine. That's fantastic and that's great for them. Again, there's so much about glaucoma that we don't know that I don't know why your friend's glaucoma is so much slower and it's so stable, but yours is more progressive. Things happen on a molecular level that we just don't know about, but we're still going to do our best to treat it. The good thing is that there are lots and lots of options to treat glaucoma now. So, can I have glaucoma with normal eye pressure? Yes, it's actually pretty common. It's called normal tension glaucoma or low tension glaucoma, normal pressure glaucoma. What's normal for others, so let's say a pressure of like 17 might be too high for you if you have normal eye pressure. Again, this is kind of plays into the thing where we don't know that it's just pressure causing glaucoma. And there's some people where we think maybe there's blood vessel issues or blood flow issues causing this. There's so many different factors here, but we still treat it the same. We try to get you to your own personal pressure goal. So every patient is different with glaucoma pressures. So people say, "Oh, well, my friend's pressure is 19. Mine's, 19. That's good." I'm like, "Well, no, for you it might be too high." So every patient is different. It depends on you and your eyes and your disease history. So, as far as treatments, I was saying, we have lots and lots of options. I usually start with what's called SLT, selective laser trabeculoplasty, if you're interested. It's kind of like a very low-powered heat treatment that helps improve that drainage system inside the eye. So, Instead of turning down the faucet, we're trying to kind of help open up and fix that drainage system. Works in about 4 to 5 people, I'd say about 70% of patients. It can last up to 2 to 3 years if it works. It brings the pressure down about 20–30%. I would say it takes even less than 5 minutes per eye, about 5 minutes per eye. I usually do both eyes on the same day. And it can be repeated if needed. It's a fantastic option. More and more data is coming out the longer this has been around that this is actually recommended as a first line treatment over starting on drops, of course, depending on the patient and anatomy and everything. But most patients, I offer this as first line because, and I say it all the time, I hate drops. I am personally bad at using drops myself. I'm not good at remembering medications. I can't imagine that most people are. They can cause irritation and they create symptoms to this asymptomatic disease. Do drops work? Yes, absolutely. Drops can work and they are fantastic and we still use them. I still use them on most patients, but I like to start with laser if possible to try to prolong, just try to keep you off drops for as long as possible. Sometimes I use laser as in addition instead of starting another drop or try to get you off a drop. But this is typically what I and a lot of my colleagues, kind of in my generation of glaucoma specialists, like to start with now. What happens if it doesn't work, right? Nothing, literally nothing happens. It doesn't cause any damage to the eye. It doesn't prevent us from doing other treatments in the future. It just didn't work. So not too shabby for a therapy that it just does nothing as the worst case scenario. No damage, it just doesn't work. Okay, then we talk about our other options. So I like to kind of balance these things. Eye drops, sustained drug delivery, which we'll kind of get into in a second, and then the minimally invasive glaucoma surgery. So that's what we get to after this laser. So let's say the laser is still not working. Okay, then what do we do next? That's when we start talking about, okay, drops versus something inside the eye that's going to release the drug over time. Or do we need to talk about surgery, which is still minimally invasive, but it's a surgery. So drops are great, but not always simple, again. So they only work if you use them. We call it the flossing effect when patients come in and pressure is great. And it's like, oh, but your testing is worse. Your disease is progressing. Well, because just like a lot of us do, you'll floss, the week leading up to the dentist, but you haven't been flossing the whole time before, and they can tell. We have the same thing. We can tell if you've just really been using your drops just leading up to the appointment and get the pressure low. We can see the results on the testing that the glaucoma is still progressing. So they only work if you use them as prescribed every single day. It is hard to remember, though. That's the problem. Like I said, I have a hard time remembering medications every day. Most people do. Life gets in the way. And they can also cause a lot of irritation and allergies. There's preservatives in a lot of these drops. It's medication that you're putting onto a sensitive tissue on your eyes. So it's very common to have irritation, and some people develop pretty severe allergies to these as well. So, sustained drug delivery, just like people can have stents put in the blood vessels around their hearts that, release drugs to help prevent blood clotting. It's the same thing with the eye. Different drugs, but same idea where we put a device inside the eye that can have a slow, sustained drug release over time that takes the place of a drop. And so right now there's only one medication on the market, one device on the market that has this, but this is the new frontier of glaucoma treatment is let's try to get people away from drops as much as possible because we know that they can cause irritation and people have a hard time remembering. So better control of the eye pressure, better control of the disease if we just put the medication inside your eye and just don't worry about it. So what about glaucoma surgeries, right? So things have changed a lot in the past couple decades, even within the last decade about, glaucoma surgeries. The goal is to improve the existing broken drainage system, or to make a completely new drainage pathway. So the lower risk ones, the minimally invasive glaucoma surgeries or MIGS, so you might have heard the phrase eye stent or hydrus or things like that, or MIGS, goniotomy, canaloplasty, just throwing out some words that you'll hear us say and see on advertisements and everything. Those are the less invasive. Now they work very, very well, but if you have exceedingly high eye pressure, they're not going to be as effective. If you have really, really severe glaucoma, those aren't going to be as effective as these other things, the traditional glaucoma surgeries, which are because they're more invasive and they're incisional. We have to actually cut into the eye and do more things. They're higher risk, but they can be more effective on more severe patients and even higher pressures that these other surgeries aren't as effective on. So it kind of comes down to your surgeon deciding, here's the stage of your glaucoma, here's where your pressure needs to be. I'm going to choose the surgery that's right for your eye. So again, kind of talking about severity, the type of glaucoma. There's actually multiple types of glaucoma. I say flavors. There's different flavors of glaucoma, and all that has to do with the exam that we have in clinic and decide what type of glaucoma do you have, what's your anatomy, how severe is your glaucoma, what are the risks and benefits of the procedure that we're planning to do. If a procedure requires that you come back to see me every couple of days, but you live all the way in like Porterville or further away, that's not a great option for you. It's not doable logistics for me, for you. Let's choose another option. So that's the other thing too. Or if you only have one good eye, okay, well, I'm going to be more selective about the procedure that we do. So many different things go into this. A phrase that's kind of popping up now, and it sounds very like Gen Z millennial, is vibes-based medicine. And it sounds silly, but I love that phrase because the vibe of, this is a vibe of, the vibe is giving, I'm going to do this surgery. It sounds silly, but it actually is very all-encompassing where the vibe includes where do you live? Do you have trouble taking medication? What are your risk factors? What's your anatomy? What's your glaucoma severity? All of these things we consider kind of put all that together. And to me, that's what I call the vibe. What is the vibe of your glaucoma? But it's all of these things that I've mentioned that kind of get all wrapped up to help me decide what surgery to do for you. And again, face-to-face consultation is so, so important. I wish we could do telehealth. That would be fabulous. But we're not there. We don't have the technology for us to be able to do a full exam, a full eye exam, and have that full discussion. So, for both cataracts and glaucoma, the things that they do have in common is we work together to decide what's best for you. I don't like to just make a hard recommendation without your input. I want to know what your concerns are with traveling, with drop usage, recovery, things like that. What's the long-term picture? I want to work with you. Same with cataracts and glaucoma. The thing with medicine now in 2026 is it's all patient based. It's all based on you individually and what works for you. It's not, one thing for everybody. And at the end of the day, I just want to improve and protect your vision. That is always my goal. That is what I do. That's why I was in training for most of my life to protect and improve your vision.